We'll move on to the next part. This obstetrics part, you need to know few things. For example, in physiological changes, we know the blood volume will be increasing and plasma also will increase. And the mother hemoglobin will decrease because will be given to the child. Fine. The question will be asked from this fibrinogen. See, all of this fibrinogen and clotting factor, it will be increased during pregnancy, except this clotting factor 11 and 13. Except clotting factor 11 and 13, all of this clotting factor will be increased. Fine. And albumin will be decreased here and proteins will be increased. So this albumin to other proteins ratio will be maintained. Okay. So remember. Then about this cardiac output, mostly the cardiac output during the pregnancy, it will be increased and it will maximum around 30 to 32 weeks. Fine. Whereas it will be increased more than this on the postpartum period. It will increase more than 70% of this in the postpartum period, remember. And in respiratory system, there will be no increase in the respiratory rate, whereas there is a reduction in this functional residual capacity and inspiratory capacity. So this is one of the important points. So if you want to remember two things, remember this and remember this. Okay. So reduction in this FRC and inspiratory capacity, whereas there is a increase in this TLC. Increase in the TLC. Okay. Total lung capacity. Fine. Then there are few important signs. This Chadwick sign, this is this bluish discoloration of the cervix and the vagina. It is known as Chadwick sign. And okay, so it will be around 6 to 8 weeks. And Osiander sign, remember it is the OC, it is the pulsatility. It is the pulsations which is felt around the cervix, the lateral wall. It is also around 8 weeks. And Goodell signs, it is the goody cervix or the soft cervix. It is the softening of cervix, it is also around 6 to 8 weeks. And Hegas sign, okay, the isthmus will be softening here. Okay, then fetal movements will be felt by the woman around 16 to 18 weeks. Around 16 to 18 weeks, it is known as quickening. It is known as quickening. Okay, and in multigravidite it will be around 16 to 18. In primary gravidite it will be around 20 weeks. Fine, and they also able to feel this Hicks. Bottom Hicks means the baby kicks. Fine, just remember because of this contractions. And about these types of pelvis, the most common one, this is this gynecoid pelvis. Whereas if you see this flat pelvis, it is known as platypod pelvis. So in pelvis where there is this type of pelvis, it is this platypod pelvis. Fine. And android pelvis, it is a triangle shaped pelvis. It is a triangle shaped pelvis. So most common one is the gynecoid pelvis and the least common one it is the platypod pelvis. And next if you see this only pelvis with AP diameter, with this AP diameter which is actually more than this transverse, it is what is this anthropoid pelvis. And because of this will be going under arrest. It will be going under this type of delivery which is known as phase 2 pubis delivery. Phase 2 pubis delivery because of this persistent of posterior occipital position. Persistent of occipito-posterior position is seen in a case of anthropoid pelvis. So easily there will be a delivery of phase 2 pubis deliveries. Yeah, phase 2 pubis deliveries. Fine. And next, this thing which is known as deep transverse arrest. So in a case of android, it will go for hanging, right? So remember, it will hang. Okay, so the phone will be hanging. So this DTA, this deep transverse arrest will be seen in a case of android pelvis. Fine. And platypod pelvis will result in this posterior acinctulum. Fine. And there are two types of pelvis. Nuggles pelvis. If one wing of the sacrum, if absent, it is known as Nuggles pelvis. If both of these wings, if both the wings of this sacrum, if both of them they are absent, it is known as Robert's pelvis. It is known as Robert's pelvis. Remember. Then you need to know about this just number of these conjugates. This true conjugate, obstetrics conjugate, and diagonal conjugate. So you know once you put a hand from the pubis tympicus to this sacral promontory, you will able to measure this true conjugate. And from this, if you minus it, it is this obstetrics conjugate, and if you add it, it is this diagonal conjugate. So just remember. Okay, this conjugates are being used to know whether the pelvis is adequate for delivery or not. Whether the pelvis is adequate for the delivery or not. Right? And we'll move on to this type of abortion. We'll call them abortions. Means if the delivery of the baby then the baby should be live outside. Then we'll call them as death. But if non-viable fetus is being born, we'll call them as abortions. Fine. So mostly, DC minus 1. Yeah, that's correct. Mostly this spontaneous abortion. The spontaneous abortion, what we'll do means it is unexplained. It will happen by its own. Okay. And most common cause of this spontaneous abortion scare, it is this chromosomal abnormalities. And there are different types of abortions. Recurrent abortions means it is defined as 3 or more consecutive spontaneous abortions before 20 weeks. We'll call them as recurrent abortions. And there are few more type of abortions like threatened abortion, inevitable abortions, complete, incomplete, and missed. So there are few delineating factors. Threatened means it will threaten you, means like it will threaten you, I will be abort, but nothing will happen. How will you threaten? Like they will threaten with small spotting of bloods. So if you just see the os of the cervical os will be closed. Okay, there will be slight bleeding, but there will be the uterus will be of normal size and the os will be closed. Whereas in a case of inevitable abortions, okay, there will be bleeding, but the os will be open. So if because of the os will be open, we cannot make them close. So it will be obviously it will come, it inevitably it will abort. So that is this inevitable abortion. Okay, right. Next, about complete abortion, there will be the history of passage of this means clot, small clots, or this fecal means fetal parts will be passed. Okay, and the uterus size will be less than this gestational age. Here the cervical internal os is also closed. While in a case of incomplete abortions, here also passage of some fleshy material. Whereas while doing ultrasound, there will be a presence of this materials and even the cervical os will be open. In complete abortion, it will be closed. Whereas in a case of incomplete, the os will be open because there is more content inside. They should come out, right? That should come out. Then about missed abortion, it is the dead or retained fetus in the uterus. It is the dead or this dead fetus inside the uterus. Fine. And usually this missed abortion, it will be having this features of bleeding, it will be having the features of delivery, like there will be this regression of this breast changes, and there will be no morning sickness or no morning vomiting. Okay, and the uterus also will become small because it's not growing, right? So it should grow based on the gestational age. Since it is not growing, so it will be usually less than the gestational age. Okay, here also the os will be closed. Okay. Then about this act, which is the MTP Act 2021. This MTP Act 2021 tells if to do an abortion till 20 weeks, okay, you need a permission from one RMP. To do an abortion from 20 to 24 weeks, you need a permission from 2 RMPs. Fine, and then you can do this delivery or do this abortion in a case of rape. In a case of contraceptive failures up to 20 weeks. So in the case of contraceptive failures, it can be done up to 20 weeks. Whereas in the case of rape, it can be done up to 24 weeks. So in the case of rape, it can be up to 24 weeks. Whereas in the case of contraceptives, it is still 20 weeks. Fine. And even after 24 weeks, this can be done if there is any fetal abnormalities are present, or if there is any problem for this mother, or if there is any death threats to this mother, then in such cases these abortions can be performed. ठीक है, आपको याद रखना. So mostly they will play with this rape and this contraceptives. So contraceptives we can do till 20th week, whereas for rape we can do till 24th week. Okay, इतना याद रखो. And for this MTP हमें किसका consent चाहिए? Yeah guys, we need the consent of woman, or only woman, or woman's guardian, or husband, or both husband and wife. Whose consent we need, guys? Yeah, good. It is what it is, the woman only. So we need consent from only woman. Yeah, good Dr. Gautam, good Dr. Sadaf, only girl consent. The woman consent only which needed. Yeah. If mentally challenged, yeah. If the female is mentally challenged, then we need the consent from the parents. Fine. Consent from the parents. Good guys. Fine. Only woman or only girl, only wife. Fine. Next, about this ectopic pregnancies. And about this ectopic pregnancy, if you see, there are different types of ectopic pregnancy. There can be ruptured ectopic pregnancy. Because this ruptured ectopic pregnancy, the patient will be presenting with features of pain and hypotension, because bleeding is going on, right? Hypotension. So in such cases, we need to go for immediate laparotomy with selfingectomy, and along with this hypotension, we need to resuscitate the patient. Fine. Whereas in the case of unruptured ectopic pregnancy, we need to measure the beta HCG levels. If the beta HCG levels are less than 1,000, and if the ectopic mass is less than 3.5 centimeter, then we can go for this expectant management. Expectant management means if yesterday it's 1,000, or yesterday it is 1,500, today it is less than 1,000, tomorrow it is 800, means it is gradually decreasing. Then we can go for this expectant management. Whereas this medical management done in a case where the heart activity is absent and the mass is less than 4 centimeter and the HCG level is 5,000. It is less than 5,000. So in such cases, we go for this medical management. A good doctor will use methotrexate. Will use methotrexate for this ectopic pregnancy as a medical management. Okay, for medical management, we'll use this methotrexate. Fine. Next, for surgical management, if there is presence of this heart, if there is presence of heart activity, and if it is more than 5,000, if it is more than 5,000, and if it is diameter is more than 4 centimeter, or it is not in compliance, or it cannot be terminated with the medical methods, in such cases we'll go for the surgical management. So we'll try to save the fallopian tube usually by salpingotomy, but in unfortunate situations we'll go with salpingectomy. Okay, we'll go with salpingotomy, or else we go for salpingectomy. Fine. Yeah, correct guys. Fine. Next, about this hypertension management in pregnancy. In a case of pregnancy, if there is hypertension from previously, it is known as chronic hypertension. Whereas if hypertension happens after this 20 weeks or more than 140/90 of blood pressure after 20 weeks, we'll call them as pregnancy induced hypertension. And if any associated symptoms, if there is any proteinuria associated with this pregnancy induced hypertension, we'll call them as preeclampsia. And if there is any seizure associated with this preeclamptic findings, it is known as eclampsia. So this is the three delineating features. Yeah, if you see the drug of choice for this hypertensive management in pregnancy, it is the labetalol, and it is the drugs which are being contraindicated include ACE inhibitors, beta blockers, and furosemide. All of them it will cause intrauterine growth retardation. So based on it, for example, if it is pregnancy induced hypertension, we can give alpha methyl dopa, or mostly we can use labetalol. Okay, whereas if it go to this preeclampsia, then also we can give IV labetalol. Whereas if it is going to eclamptic seizures, then we can go for this magnesium sulfate. If it is impending preeclampsia or impending eclampsia, then we'll go for this one, which is this magnesium sulfate. Okay, so treatment of eclampsia it is the magnesium sulfate, which is given in this Picard's regime. So dosage 14 grams, loading days 4 grams IV देंगे और 10 grams in each buttocks. 10 grams in 10 grams को 5 grams में each buttock में देंगे. ठीक है, remember. Then delivery means one of the main reason for this pregnancy induced hypertension it is because of this failure of invasion of this secondary villus. Okay, secondary villus का invasion की वजह से ये होता है. So because of this fetus, this thing is happening. Okay, so because of this fetus, this thing is happening. So if you remove the fetus, then everything will be resolved. So see, so the definitive management it is the delivery. Okay, it is the delivery, it is the definitive management. So what we need to do, initially we need to continue with this magnesium management, and we know once we give this magnesium sulfate in a case of eclampsia or if any seizures occurs, तो उसके बाद हमें क्या करना, we need to monitor for this magnesium toxicity. And how we'll monitor? We'll monitor with this patellar reflex. Patellar reflex is the first thing to be lost in a case of magnesium sulfate toxicity. फिर उसके बाद हम उनका respiratory rate देखेंगे, क्योंकि there will be respiratory depression will be there. Then the urine output, because magnesium will be excreted through the urine. So तीनों चीज देखेंगे, the patellar reflex along with the respiration and the urinary output. ठीक है, so remember. So in a case of BP control के लिए हम क्या करेंगे, IV labetalol. So if it is mild, then we'll move on to few scenarios. If there is mild preeclampsia patients managed with fetal monitoring, and hypertensives like labetalol can be given, and if it is mild, we can go up to 37 weeks. Fine. If it is severe, like more than 160 BP, 3+ proteinuria, and signs of end-organ damage, okay, then we need to give magnesium sulfate because they can have seizures. And second, we need to control the hypertension. At the moment, we'll give this labetalol. And definitive management क्या है, सब में बच्चे को बाहर निकालना. ठीक है, to terminate the baby, if it is more than 34 weeks, we'll give steroids and we'll terminate it. Fine. In case of eclampsia, where convulsions have been already occurred, our main role is to give magnesium sulfate, फिर उसको जल्दी से जल्दी उसको निकालना. ठीक है, so it is one of the indications for the cesarean section. Okay, in patients of this type, there will be a features which leading to this hemolysis, elevated liver enzymes and low platelets. So hemolysis, elevated liver enzymes, and low platelets. All of them, they will lead to this syndrome, which is known as HELP syndrome. So in such cases, we need to terminate the pregnancy, which is around means if it is more than 34 weeks, then we need to give steroids. Yeah, as told, will in India mostly will prefer dexamethasone, or else we can also give betamethasone. Okay, dexamethasone 6 doses, 6 mg for 4 doses with a means with the variation. Fine. Whereas betamethasone will give 12 mg 4 doses. Okay, 24 hours apart. Whereas this is 6 mg 4 doses 12 hours apart. Okay, this is the dexa. Then about this, top in all this case, vaginal or CS, is that important? Yeah, no, like in a case of most of this pregnancy, what we'll do, like if you see about this pregnancy, in a case of hypertension, हमें जल्दी से जल्दी बच्चा बाहर निकालना है. So mostly what we'll do, we'll go for this cesarean section if there is any convulsions are taking place. But if it is manageable, then we'll go for usual normal vaginal delivery. Fine. If it is being controllable, fine. If not, we'll go for this cesarean section. So one of the main indication, as I told you, right, if there is eclamptic seizures happening, the female is taking seizures, then it is one of the indication for cesarean section. Whereas if there is any no fetal distress, just hypertension, then we can manage the hypertension, we go for labor. So this is the delineation part. If eclampsia, like if you want to remember one thing, remember if there is eclamptic seizures going on, then we need to do cesarean section. If not, we need to go for usually normal labor delivery by controlling this hypertension. Okay? Yeah, that is the thing. Then about diabetes management in pregnancy, usually we can initially start with this diet chart or diet management. Okay, then followed by which mostly we'll use oral, means we'll use insulin. If you want to use oral hypoglycemic drugs, the metformin is preferred. Okay, this is a simple definition. If you see, and we screen all the pregnant females in their first antenatal visit itself. Okay, and if it is normal, then we'll repeat around 24 to 28 weeks. Okay, so it is one step screening. We'll give 75 gram of glucose. We'll take the fasting level, 1 hour level, and 2 hours level. Okay, fine. And if the fasting level is more than 126, or if the fasting level is more than 126, we'll call them as over diabetes. Whereas if the fasting level is more than 92, 1 hour level is if this more than 180, or if the 2 hour level is more than 153, it is like just around this twice, like 90 into 90, it is 180. So you just remember first two, it is 92, 180 after 1 hour, and 153 after 2 hours. This is the diagnosis for this gestational diabetes mellitus. Whereas if it is more than 126, if the fasting itself, then we'll consider it is a over diabetes mellitus. And remember one thing, none of these congenital anomalies will happen in a case of gestational diabetes mellitus. All of them will be happen in a case of over diabetes mellitus. Okay? And what are the complications can happen? This include hypoglycemia and hypocalcemia. So they will ask you, yeah, mother is delivered a baby, a diabetes mellitus mother has delivered a baby, and what are the following electrochemical abnormalities he will check? He will check for hypocalcemia. Fine. And next he will check for hypomagnesemia, and there will be polycythemia, and hyperbilirubinemia will be there, and mainly there will be maxillosemia. And if it is a case of over diabetes mellitus, then it will lead to this abnormalities like transposition of great arteries, which is more specific heart anomaly, whereas overall most specific it is the sacral agenesis. Next about this management part, like as I told you, we need to restrict their calories. Usually हम 30 calories per kg देते हैं, लेकिन diabetes के लिए 24, and we can restrict up to 20 kilocalories per kg per day दे सकते हैं. ठीक है. And the drug of choice is insulin. अगर आपने oral hypoglycemic agents देना है, तो we can give either glyburide or metformin. ठीक है. और fundus examination करेंगे if there is a presence of any retinopathic features or any features of proliferative retinopathy. ठीक है. And timing of delivery, if you see gestational diabetes mellitus, अगर उन्होंने बस डाइट पे कंटिन्यू किया तो 39 वीक तक हम ले जा सकते हैं. अगर if it is gestational diabetes mellitus, if it is controlled on medication, then we can continue till 38 to 39 weeks. Means around 30, after 37 weeks will deliver around 38 weeks. If it is over diabetes mellitus, continued on insulin मतलब more than 37 weeks हम डिलीवरी करेंगे. And if it is over diabetes mellitus, if it is not controlled, फिर around 34 weeks हम क्या करेंगे, स्टीरॉइड्स देंगे तो बच्चे को बाहर निकालेंगे. ठीक है, स्टीरॉइड्स देके निकालेंगे, बस इतना याद रखो. Then about this management, which is this postpartum hemorrhage. You know, postpartum hemorrhage, if it is more than 500 ml in a case of cesarean section, and if it is more than 500 ml in a case of vaginal delivery, or if it is more than 1 liter in a case of cesarean section, we'll call them as postpartum hemorrhage. And in postpartum hemorrhage, usually there will be a decrease in hematocrit by 10% or 1% decrease in their hemoglobin level. Okay, 1% decrease in their hemoglobin level. And one of the most common cause of death in pregnancy death in India, it is what it is, this PPH, which is the maternal mortality in India, it is PPH. Okay, and there are different causes for it. We know this tissue tonicity, and there will be trauma, and there is this clotting factors. So all of them, they can lead to this PPH. So most common cause it is the tonicity. That's why we give oxytocin to induce this tonicity. Okay. So then if PPH occurs, how will you manage? First, to improve the tonicity, we'll give oxytocin. Followed by this, to improve it, we'll give carbitocin. तो उसके साथ साथ उसी टाइम हम क्या करेंगे, ट्रानक्सामिक एसिड भी देंगे. ठीक है. Then we'll give this methyl ergotamine. लेकिन there are few contraindications. For example, this carbitocin, it is contraindicated in the case of bronchial asthma. Okay, because it causes bronchoconstriction. This methyl ergotamine will be contraindicated in the case of hypertension and any cardiac condition. So methyl ergometrin will be contraindicated in the case of any of these cardiac conditions or any of these heart diseases, and along with this RH negative pregnancy. Kyunki this methyl ergometrin, it won't produce this symmetric contraction, it will produce this vigorous contraction. So because of this vigorous contractions, this RH negative pregnancy, it may alleviate the RH negative pregnancy, and it may damage this heart again. Okay, and heart cannot pump this much fast, right? And next, about this misoprostol also can be given. Okay, either in per rectal, we can keep it, fine. And carboprost, which is the go-to drug. If nothing works, then we can use this carboprost. Remember. Then if none of them works, what we can do is that we can use some of these tampon methods. Like this is known as Bakri balloon, where we can give compression with 500 ml. Okay, which can use as a pressure stem. And next, first we'll give this Bakri balloon. Along with this, we can use other methods like condom catheter, or we can do this specific uterine artery embolization if they don't want to preserve fertility. So all of these methods initially we can do. So if none of them works, then we can go take them into laparoscopy, take them into this OT, and we can do this suture, which is known as B-Lynch suture. Okay, this type of B-Lynch suture, or else we can do this Heyman suture or this box suture. Okay, then followed by this, if we see, if the patient is stable, then we can go for this uterine artery devascularization. Okay, so we'll give this pressure compression. If nothing works, then if availability of this artery embolization, will go for it. If not, we'll go for this OT, and we'll go for this Heyman suture and B-Lynch suture. If nothing works, we go for this uterine artery devascularization. Our OB काम नहीं किया, because if this bleeding from this ovarian artery parts, then we'll go for this hysterectomy. Fine. The final one, it is what? It is the hysterectomy. Okay. And next, one of the antepartum hemorrhage, it is what? It is this abruptio placenta. In a case of abruptio placenta, it is the blood from the female part. It is the blood from the female side. So if you see this abruptio placenta, the female will be having this tense abdomen. The female will be having this tense, tender abdomen. If you touch it, will be painful, and she will tell she is unable to feel the fetal movements. Okay, and tense, tender abdomen, unable to feel the fetal movements. And there will be two methods. Two types. One is known as concealed type of abruptio placenta, and another one is known as revealed type of abruptio placenta. See, this concealed means it is occurring behind this placenta. So it is known as concealed. Whereas revealed means it is occurring on the side, so that the blood clot is visible as bleeding. So here there will be a thing which is known as pallor, which is out of proportions to the bleeding. So there is a pallor in the female, but it is not proportion to the bleeding. The bleeding is less, but the pallor is more. Okay, there is a pallor which is usually out of proportion. Okay, and there is abdominal pain, bleeding per vaginum, abdominal pain and bleeding PV. Okay, and there is this loss of fetal movements. Fine, and the uterus will be tense and tender. And sometimes this blood may go and enter, this concealed varieties can go and enter into the myometrium, and to produce this type of uterus, which is known as what? Which is known as squamous uterus. It is known as squamous uterus. Okay, it is known as squamous uterus. So in the case of abruptio placenta, the main management, it is what? It is the delivery. Mostly we deliver by normal vaginal delivery. Okay, we'll do this artificial rupture of membrane, and we'll give this oxytocin drip, and we'll do vaginal delivery here. Okay, just remember, And if the baby is under stress, or if the baby is very much immature, then we'll give this steroids for this lung maturity, and we'll try to do by mostly we'll try to deliver by this normal vaginal delivery. Okay, and sometimes it may lead to the causage of disseminated intravascular coagulation. Okay, if the baby is dead also, then we go for this normal vaginal delivery only. So in very unfortunate situations where the baby is under very stress or very fetal distress, then only we'll go for cesarean section. Whereas rest in most of the cases in abruptio placenta, we'll go for normal vaginal delivery. Fine, with ARM. And next about this placenta previa. Usually the placenta will be upper and posterior in location, whereas if instead of this, if it is located near this os, we'll call them as low-lying placenta. Okay, or placenta previa. So initially it will be low-lying placenta. If it is touching the margin, we'll call them as marginal placenta. If it is coming half of it, we'll call them as partial placenta previa. And if it is completely obstructing the os, it is known as complete placenta previa. ठीक है, तो इतने आपको याद रखना. Then there is a sign which you see, if you press or compress the baby, then it will go and compress this umbilical cord, and it will cause what? It will cause decrease in the heart rate. So this is known as what? This is known as stall for this side. It is known as stall for this side. Fine, okay. And in a case of this placenta previa, see, this placenta is lying on the internal os. The placenta is lying on the internal os. So if you do this perivaginal examination, you will go and hit and it will cause bleeding. So in such scenarios, mostly what you will do cesarean section as a part of management. In case of very low-lying placenta, you can try. Whereas in the case of partial placenta and complete, you will try for the cesarean section. Okay, cesarean section, even if the baby is dead. Okay, you can try one method in the case of this type of marginal, where you can have this OT setup and you can go for this gentle PV examination. If bleeds, then you can just cut open and you remove the baby. Okay, and what are the indications of this management, which is known as expectant management? It is known as, usually we won't do PV in the case of placenta previa. It is known as McAfee and Johnson's regime. It is known as McAfee and Johnson's regime. So what are the indications? There should not be active bleeding. It should be, the patient should be hemodynamically stable, and the gestation age should be less than 37 weeks, because for this maturity part, and CTG should be reactive, and no fetal anomaly should be seen on the ultrasound. Fine. Next, about the stages of the labor. We know the initial first stage of labor, it is divided into two parts, the latent one and the active phase. In latent phase, okay, latent phase, it is what it is, this pain up to 3 centimeter dilatation, and from 3 centimeter to this complete dilatation, for what it will call them as active phase. We know this latent phase, it can go up to 20 hours in primary gravida or 40 hours in multigravida. So if it is more than 20 hours, then only we'll call them as prolonged first stage of labor or prolonged latent phase of this labor. And if it is more than 14 hours, we'll call them as prolonged latent stage of labor in multigravida. Fine. Whereas in the case of active phase, it will be sudden in nature, and second stage if you see, it will be in primi, it will take 1 hour, whereas in multigravida it is just 30 minutes. It is just full dilatation followed by coming out of the head, okay, coming out of the baby. Okay, then about this third stage, it is the expulsion of the placenta. Okay, it will take around approximately 15 minutes, and if it is more than 15 to 30 minutes, then we'll consider that is a retained placenta. Okay, fine. And fourth stage, it is the stage of observation. Fourth stage, it is the stage of observation. Fine. And this is here we take this active management of this third stage of labor. In the case of active management of this third stage of labor, what we'll do? We'll do administer the oxytocin. Once this placenta is delivered, once this baby is delivered, then we'll give oxytocin. Okay, we'll give oxytocin after immediate delivery, and after that we deliver this placenta by one hand you will put into the uterus, and with another hand you will with the corkscrew motion you will gently drag this placenta. Okay, with this corkscrew motion, it is known as gentle traction, and followed by this, what you will do? You will do delayed cord clamping. Until unless there is an indication, you will do delayed cord clamping. And as per the WHO protocol, the uterine massage, to increase the tonicity, uterine massage is not mentioned. Okay, but it can be advised, but uterine massage is not mentioned. But okay, it is uterine massage. Remember, it is not fundal massage, it is the uterine massage which can be done to prevent this tonicity. But usually it is not done as per the WHO protocol. Fine. And what are the methods of this breech extraction? So in the case of breech delivery, you know the sacral will come first. So to remove this head, we'll use this maneuver which is known as Mauricio Smiley maneuver. So in this case, remember, we smile with this maxilla. So it is known as Mauricio Smiley with maneuver. Fine. And next, to deliver this head, we can deliver in arc fashion, like you keep a hand like this and you will deliver like an arc. So in a case of arc facially, if you deliver this child, okay, it is known as what? It is known as Marshall's technique. Marshall's technique. Okay, yeah. Then if you're able to see, if you rotate the child to remove this shoulder button to come, it is known as what? It is known as low set maneuver. Okay, and you went in and तुम पीछे से गए हो और इनका पोप्लिटल फोसा में उंगली रख के इनका पैर को निकाला, तो पीछे से पोप्लिटल फोसा से देन पैर को. So all of this PP1 will be seen in a case of Pinard's maneuver. Pinard's maneuver. So it is the Pinard's maneuver. Yeah, good, Dr. Anna. Then this is the episiotomy. So remember, in the case of episiotomy, there are two types of episiotomy. This is midline episiotomy and this is the mediolateral episiotomy. So we perform mediolateral episiotomy. Yeah, mediolateral episiotomy. And remember, episiotomy, it is not mandatory, it is optional. It is optional. Okay, it is optional. Okay, it can be done, it is not always recommended. Okay, remember. And then there can be degree of perineal tears. For example, during the delivery, you need to give support to the perineal body, but if you didn't give support, then it leads to the formation of this perineal tear. This perineal tear, if it just vaginal mucosa is getting eroded, if just vaginal mucosa is getting eroded, then it is the first degree. If along with this vaginal mucosa, there's the muscles of this perineal body is getting involved, it is the second degree. If along with this vaginal mucosa, along with these muscles, if the sphincter is involved, okay, if the sphincter, anal sphincter is involved, it is the third degree. If along with this muscles, mucosa, vaginal mucosa, and along with this sphincter and along with this rectal mucosa is involved, it is the fourth degree. It is the fourth degree. And whatever is this perineal tears, it should be repaired immediately. It should be repaired immediately. But if the patient comes after 48 hours, we'll tell them to wait for 3 months. Okay, then we'll repair it. We won't repair immediately. We'll tell them to go for this secondary healing. Fine. And there are few normal puerperal changes. If you see about this normal puerperal changes, this lochia will be the secretions, lochia rubra, serosa and alba. Lochia rubra, serosa and alba. Fine. And usually the pulse will be increases because there will be increased blood supply, because previously the baby is also receiving blood supply. Now the entire blood is circulating into the mother, so there will be increase in heart rate initially, and there will be loss of weight because of this diuresis, and then the blood volume will start to decrease. Then the fibrinogen and ESR remains high. Okay, cardiac output, as I told you, it will increase more than 60 to 70%. Okay, 60 to 70% more than the pre-labor value. Then in urinary tract, there might be retention of urine and there might be a constipation in the GIT tract. Okay, fine. And they will ask you after 2 days how much distance the uterus will be. After 2 days, like every day it will reduce by 1.25 centimeter per day. So after 2 days it will be around 2 centimeter. It will be 2 fingers from the umbilicus. Okay, itna yaad rakhna. Okay, and it will become a pelvic organ by 2 weeks. And it will become a pelvic organ by 2 weeks. Okay, and we'll move on to this few instruments. This is this iris spatula, and this is this cyto brush. Iris spatula, it is for this ectocervix. It is for this ectocervix. Whereas the cyto brush, it is for this endocervix. Yeah, a good, Dr. Anna. Whereas this one, this is this cytobroom. Cytobroom. With cytobroom, we can scrap both ecto and endocervix. Ecto and endocervix. Ecto and endocervix. Yeah. Fine. And this is known as, it is known as visual inspection under acetic acid. Visual inspection under acetic acid for this 3A cervix. Fine. And next we'll use this 3 swab test for vesicovaginal fistula. See, in the case of vesicovaginal fistula, we need to check from where there is a leakage. So we'll put 3 swabs, 1, 2, 3 swabs. Okay, and we'll instill some dyes. And when we instill this dye, we'll see, like if there is from this ureter direct connection, then it will come, the urine color will come. But if it is from the bladder, and if it is coming on the first, it is what it is, this vesicovaginal fistula. And if it is below, it is this urethrovaginal fistula. So it is different types will follow. Then this is what? Menstrual regulation syringe. Okay, and this is the manual vacuum aspiration. And for this we'll use this cannula, which is known as Carman's cannula. Fine. We'll use this Carman's cannula. Fine. We'll move on to the next part. These are the few instruments you need to know. This is this episiotomy scissor, and this is the Hagas dilator which we use during this incompetent cervix to see whether the cervix is dilated or not. And this is the ovum cervix, ovum holding forceps. Yeah. This is the ovum holding forceps. This ovum holding forceps we use to remove this debris during the DNC. Okay, during DNC. Okay, and it will be without lock. It will be without the lock. Okay, and this is the uterine curate. It is the uterine curate, and this is this Cusco's self-retaining speculum. And finally, this is this valcellum forceps. This is the valcellum forceps, and there are few more forceps. If you see this kind of knob, it is this Killian forceps, and if you see this type of perineal curve, it is this outlet forceps. Fine, and this is the Sims forceps, and this is N-shaped one. It is the Doyne's retract. Okay, retract. We'll see this. Yeah. We'll see this contraceptives, and we'll see few extra aids, and that's it for the day. Okay, so about this emergency contraception, okay, we'll be having this combined OCPs, either two methods, UPSI method and Lancy methods, which will be used less than 72 hours, and we'll use this pill which is known as I pill, which is this LNG having 1.5 milligram. Okay, it is this emergency pill also known as I pill. Okay, this is the progesterone. If we can use just progesterone only pill, it is for less than 72 hours, and IUDs like intrauterine device we can use till 5 days. And mifepristone also we can use, which is this less than 32 hours. And actually this progesterone, so that's what, there is a few differentiating factor will be there. Like you see them, like most of them you just rewind and see once more. Most of them I'll told you some mnemonic. For example, curate, it looks like your tongue cleaner, whereas this ovum forceps, it will be without the lock and it will be having this scoop. Fine, whereas this valcellum, it will be having this tooth. Okay, this Cusco's, it is a self-retaining, means if you just click on this, screw it up, it will be self-retaining. So one will be having is their peculiar features. So you try to see once more time, you will get it. Fine, and mifepristone we can use it, and next high dose estrogen also we can use it. So but most commonly used it is this LNG pill, which is this 1.5 mg. Okay, yeah. The Sims forceps, what we'll use means you need to retract. For example, you need to examine the vaginal wall. So then what you need to do, there are two Sims forceps. There is anterior vaginal wall and posterior vaginal wall. So what you will do, it will be like this. Okay, it will be like this. So what you do, you hold and you will retract the vaginal wall. Okay, that is how the use of Sims. Okay, right. Then about this few irreversible contraceptions, if you remove this fimbriectomy, it is known as corners fimrectomy. Okay, and if you remove the tube, okay, and you bury this mesosalpinx into the serosal layer, it is known as Uchida's method. Uchida's method, you will bury inside, you will bury them. Then if you cut like this, it is known as what? It is known as modified polymerase technique. Modified polymerase technique, right? And there are few more contraceptives. If you see, this is the male condom, which is marketed as Nirod, and this is the female condom, which is having this 1 and 2 rings. This is the 1 and 2 rings. Fine, it is this female condom. And using of this, with this use of the cervical mucus, if you are assessing this fertility period, it is known as Billings method. Okay, and this is the diaphragm, fine. And there are two malas, mala N and mala D. Mala N is for free and mala D for $. It is around 3 rupees per packet, and both of them will be having this ethinyl estradiol of 30 mcg and levonorgestrel of 150 micrograms. Fine, 150 micrograms, out of which 21 will be having this combination of this hormones, whereas the last 7 will be having this iron tablets, because for this withdrawal bleedings. Fine, withdrawal bleedings. Yeah. Next about this, which is known as what? Anthera. In the case of Anthera, it is the DMPA, depometroxy progesterone acetate. It is an injection formulation. Okay, and it is in injectable form, and it is given once every 3 months. Okay, once every 3 months of 150 milligram. Fine. And about this, is this senchromapin tablets, which is the what? Which is a non-steroidal tablets, non-steroidal one. Okay, and it is marketed as Chaya, and previously it is known as Saheli. Chaya, Saheli is actually what? Which is this ormeloxifene, and it is a selective estrogen receptor modulator, and it is a non-hormonal pill. It is a non-hormonal pill. Okay, remember. And it is also once a week pill, whereas for first 3 weeks it is twice a week. Okay, after that it will become once a week. Okay, twice a week for first few weeks. And next, this is this Lippel's loop, and if presence of copper in the arm, it is 380A, and it will be for 10 years, whereas it is what? It is this multi-load. Yeah, a good doctor Bhagov, good doctor, yeah, Anar, yeah, it is multi-load 375, it is for 5 years. And next one, this is the Mirena, this is this LNG secreting one. Okay, and it is also for 5 years. Remember, it is the Mirena. Yeah, good guys, good Bhagov. Fine, these are few extra G you should know. This chorionic villi sampling, it is done around 10 to 13 weeks. Okay, and we'll aspirate this chorionic villi, and amniocentesis we do after more than 16 weeks, whereas chordocentesis we'll do after 16 weeks. So 16 to 18 weeks we'll do amniocentesis, 10 to 14 weeks we'll do chorionic villi sampling, whereas more than 18 weeks we'll do chordocentesis. Fine. And shoulder dystocia, last time they asked, this time they may ask. First, for shoulder dystocia, what he will do? He will bring the female to the table and he will make her hip to flex. Okay, he will make her hip to flex. Okay, like this. So it is known as Mac-Roberts maneuver. First, he will do Mac-Roberts maneuver. Followed by this, what he will do? He will give suprapubic pressure. This is the pubic symphysis. He will give pressure here. So it is known as suprapubic pressure. Okay. Then after giving this suprapubic pressure, okay, suprapubic pressure, okay, he will also again he will press the leg. So it is known as Rubinstein maneuver. So first he will bring the female to the end or the corner of the table, then he will flex her hips, so give the mobility so that the head can come out. Okay, shoulder dislocation means like after delivering the head, the shoulder should come within 30 seconds to 1 minute. So if it is taking more time, it is what it is known as shoulder dystocia. Okay, so for that, first you need to bring the female to this corner of the table. Once you bring the female to this corner of the table, then you flex the hip. Okay, flex the hip, then you will give the more space. Then what you will do, you will give the suprapubic pressure along with this pressing. Okay, and after that, what you can do more is that you can do one more maneuver, like where if nothing helps, for example, you brought them and if you still giving pressure, the baby is not coming out, then what you can do is that you can do this Wood's corrective maneuver, so that you can correct and you can bring this shoulder to the outside. So if nothing, if then works, you can make her like a dog. So it is what it is known as to roll on a 4 limbs. It is known as Gaskin's maneuver. And finally, if nothing helps, then you can restitute the head and you can push inside, which is known as Zan-Wellis maneuver. And you push the head in and you do cesarean section. You push the head in and you do cesarean section. Okay, just remember, first it is the Mac-Roberts maneuver, and followed by this you do this Gaskin's maneuver, Mac-Roberts maneuver, then suprapubic pressure. Followed by this you do this 4 limbs, which is this Gaskin maneuvers, and followed by which you do this Zan-Wellis maneuver. You do this Zan-Wellis maneuver. So remember, okay, these are the maneuver which we do for this shoulder dystocia. Okay, fine. And next, if you see, these are 2 twins. If you see this type of thick septum, okay, between these 2 tens, it is known as, see, this is the thick twins, thick one. Okay, and it is known as lambda sign. Okay, remember how you will remember this? Remember it as moti. Okay, moti को हम प्यार से लड्डू बुलाते. Okay, so remember, in the case of dichorionic diamniotic twins, there will be lambda sign. Okay, there will be this lambda sign in the case of dichorionic diamniotic twins. Whereas in monochorionic twins, there will be what? There will be this thin membrane. This thin membrane is known as what? It is known as which sign? Yeah, it is known as T sign. Yeah, good Dr. Abneet and good Dr. Anar, good Dr. Baba. Good. Fine. And finally, this variations of the placenta, if you see side, instead of attaching to the center, if it is attaching to the side, it is known as battledore placenta. And if there is any thickening of this placenta, it is known as circumvallate placenta. And if you are able to see two lobes. There is one primary lobe and secondary lobe. It is known as succensurate placenta. Yeah, and in this succensurate placenta, it can lead to this secondary PPH. And next, if instead once joining only this this cord, umbilical cord should start separating. If it separates before itself, if it starts separating before, okay, then it is known as what? Then it is known as velimentous insertion of cord. It is known as velimentous insertion of this cord. Yeah, good, Dr. Gautam. And this can lead to this placenta, means this can lead to this vasa previa. Means in a case of vasa previa, the bleeding from the child will be there. Fine. And next, about the cervical incompetence. Cervical incompetence matlab means the cervical will be short, so that there will be a recurrent abortions will be happening. So usually it will be the second trimester abortions, and the cervical length it will be less than 2.5 centimeter. If it is less than 2.5 centimeter, then the baby will automatically come out. So this is known as what? Cervical incompetence. So in such cases, we'll do the cerclage, which is known as McDonald cerclage. We'll do the cerclage, which is known as McDonald cerclage. Finally, this Leopold's maneuver. If you see this Leopold's maneuver, there are 4 maneuvers. This one, it is known as, we'll see this fundus. What is the presenting part? Like based on it, if it is head is here, head is on the fundus, then we'll think, yeah, when the baby is sitting, it is a breech presentation. If multiple irregularities is there, then it is what? Then it is limb, then it is a cephalic presentation. So Leopard 1, it is to assess which is the presentation. And then based on the lie, like if it is both this with in relation to the female spine, we'll check. If it is like this, if the baby is like this, okay, then it is transverse lie. If it is like this, it is the longitudinal lie, and if it is the oblique lie, and it is the longitudinal. And in third, we'll check whether what is the presenting part, whether the head is there or sacrum is there again. So if head is there, it will be a single palatable mass, whereas sacrum, there will be multiple parts will be there. Whereas in fourth, we'll see whether the baby part, which is presenting part, is engaged or not. So if two hands meet, then the baby is not yet engaged. So see, if two hands meet, means that baby head is still here, it is not engaged. Whereas all of this first, second and third, it will be facing the woman. The final one, the fourth part, will be facing the foot of the female. Yeah, correct. Okay, this one is this first pelvic grip. Okay, this is the second one. Okay, remember. And here, if two hands meet, it is not yet engaged. If it is not meeting, means the head is engaged and it is going to deliver. Fine. Molar pregnancy, and this molar pregnancy will be having this no chrome appearance. If only mole is there, then it is what? Then it is complete mole. If it is mole along with this fetus, it is the partial mole. Remember, it is the partial mole. If it is only mole is there, it is the complete mole. Okay, and we know in the case of molar pregnancy, there will be more vomiting because of increased levels of beta HCG. Okay, we'll do this beta HCG monitoring to check for choriocarcinoma as well, and we'll tell them which of the following contraceptive is contraindicated here. Will contraindicate, means the contraindicated IUDs, intrauterine devices, IUCDs, there will be contraindicated in the case of molar pregnancy because the uterus will be soft, it can lead to the perforation. Okay guys, these are the most important must-know topics from the gynecology and obstetric perspective. I guess you got some understanding from it, and if any queries, I will open to it, and just have one thing in your mind, that you can do it and you have the will to do it, and just stay consistent for next few more days and you will be doing it. Fine. If you have any doubts, please connect with us, or else we'll catch up tomorrow. Fine. And your final day.